Now we will listen Riccardo about ectasia diagnosis. He is from Milano. Thank you so much, Riccardo. Sorry for late.
No worries. So it sounds a bit strange because all of this webinar was about IOL, so I feel a little bit out of place now, but they asked me to speak about ectasia assessment, and so here we go. I'm going to speak about a new way, actually it's probably is the only way to diagnose ectasia with post-LASIK ectasia with an index. And okay, so my financial disclosure, the first one is relevant for this talk because I collaborate with Oculus since many years. And so laser vision correction is a very safe and accepted procedure to correct refractive errors. It has an excellent profile, but in a small amount of case, PRK, LASIK, or SMILE, all the three of them can cause iatrogenic ectasia. And the sooner we diagnose ectasia, the better it is because we can treat it with crosslink. Up to date, there is no gold standard to diagnose ectasia. If you go online in PubMed and you see all the possible algorithms to diagnose it, they always rely on 2 scans. So they say a change of astigmatism, a decrease of vision, increase of curvature. So it's not one diagnosis like we do in keratoconus, for example. So the incidence of ectasia is very low, but it can come even years after the surgery. And we know that if ectasia is not treated, it can be as severe as it's needed to do a DALC. And there is no evidence that even SMILE induces a lower amount of ectasia cases. Very recently, there was a study in which they showed that the biomechanical change induced by LASIK and SMILE 1 month post-op is the same. LASIK extra, similarly, does not prevent ectasia as there is no long-term randomized trial that proved that LASIK extra is safer than LASIK, the normal LASIK. So how can biomechanics help? We know that in keratoconus, the primum movens, so the first hit of keratoconus is the change in biomechanical properties. So if this is the case, we could also use corneal biomechanics to help the diagnosis of post-LASIK and post-refractive surgery ectasia. But there are many challenges. The first one is that you need to be able to separate normal patients from keratoconus, then stable patients that are normal. So stable post-laser vision correction patients are abnormal with any indices, even TBI and CBI, because they are designed to separate normal from keratoconus, not stable patients after laser vision correction from ectasia. So then to be able to separate from a stable LASIK patient from an ectasia, you need a very large database. So we asked for help from all over the world, going from Rio de Janeiro to Japan, to Germany, to India, because we needed a very, very large database. And we have used the Corvis to create this new index. So our index is aimed to separate patients that are stable after surgery with ectasia, and also to create a semi-automatic approach to separate healthy patients from keratoconus and keratoconus from laser vision correction patients. So let me show you the AIM one. We created a new index with 736 patients. They were enrolled in different continents because what it was very difficult to find cases with ectasia post-laser vision correction that are very rare, as we know, that were not treated with cross-linking yet. And also to have stable patient with at least 2 years of follow-up. So there were 785 stable patients, LASIK, SMILE, and PRK, and 51 post-laser vision correction ectasia patients, most of them after LASIK, but there were also 2 from after SMILE and after PRK. So, sorry, this is a mistake, is at least 2 years of documented stability, and all surgery were done by very well-known world leader of refractive surgery. The ectasia were confirmed at least by 1 masked cornea expert. The statistical analysis was a logistic regression but we used two databases, one for creation of the index and the second one for validation. Particularly 20% of the database were used as validation. The CBI LVC is this new index, and as I was saying, is aimed to separate stable from ectasia patients. In the training dataset, the sensitivity was 100% and the specificity was 97. And in the validation dataset, the sensitivity was 93.3 and the specificity was 98.51, which means that was also accurate in the validation dataset. But in clinical practice, well, you need something else. As I was saying, you need, if the patient comes to your clinic and the patient doesn't know, which is very rare, but doesn't know if they had refractive surgery. Sometimes it happens, very rare, but also it's easy to have something like that in the clinic. So we also created another index that was aimed to help even in the separation of patients in a semi-automatic approach. We needed even more patients because most validated indices for detection of keratoconus, such as KISA score, BED-D, CBI, and TBI, are unable to distinguish between a keratoconus and a post-refractive patient. So then we needed an even larger data set. So we included 4,280 patients, and they were also enrolled in different continents, and they were healthy controls, keratoconus, stable post-LVC, and ectasia, the same as before, the last two groups. The healthy patients were absolutely healthy with no previous surgery, no high myopia, no concomitant medication, and the BED-D was at least less than 1.6. All patients were confirmed by another expert. Keratoconus, bilateral clear keratoconus with no previous ocular procedure. And the other two were the same as before. Statistical analysis was working like that. If you have a patient, is it abnormal, yes or no? We used the CBI to separate between normal and keratoconus, and I will explain you why. Because as we said, CBI is also abnormal in patient after laser vision correction, which means that you can use it efficiently to separate between normal and the rest. Then we created a second index to separate between keratoconus and post-LVC. And at the end, we were applying the CBI LVC to separate between ectasia and stable patients. I will just skip the steps of the statistical analysis because of time concerns. And I'm going to show you directly how it works in the clinical practice. So this is a keratoconus patient. As you can see, this is the tomography and biomechanics report. You can see that the CBI is abnormal, the BED-D is abnormal, and the TBI is abnormal. And also in the Vinciguerra screening report. So this is as usual. What about if you have a stable patient? You will have a warning that will tell you post-LVC recognized, and you just confirm which surgery had. Or in case you don't know, you just click post-LVC. And then everything gets grayed out except of the CBI LVC, which the cutoff is 0.5. So everything that is less than 0.5 is normal. Same thing is the Vinciguerra screening report. You just get it in the bottom right. You click, and then you get the CBI LVC, which is obviously the same. This is a post-laser vision correction ectasia. You still get the warning. You click, and then here you can see that the CBI LVC is 0.91, so clearly abnormal. And the same thing is in the Vinciguerra screening report. Okay, I think I'm done, and I'm right on time in 10 minutes.
Thank you, Riccardo, for nice presentation. I think you have no time to stay for questions. But for us, this is really wonderful work. This is great job, very informative. I would like to explain you, speakers choose their own topics by themselves. It was nice coincidence. Please don't feel you are outside. This is just coincidence. So thank you so much. We will not take your time. Is there any question
for Riccardo?
I have a quick question for you, Riccardo.
Hi, Michael.
So, hi. So you trained your data set, and then you validated the data set. They were independent data sets.
That's correct.
Okay.
That's correct. So basically, what we have done is that we have used 80% of the database, but the 20% is independent on the first 80%.
Okay, but this is not, so it's the same data set, but you just splitted it.
Yes, that's correct. That's correct.
So you did the data verification, not a validation, where you have now a complete new data set that you can test against.
So, sorry for my wrong reply. So, what we have done in the first CBI, so the one of keratoconus and normal patient, we did this. So it was one database that was completely independent from the second one, and we did the validation. So what I asked to, well, maybe this is wrong, but I asked this to one guy that was quite expert in stats. He suggested me, with the fact that most patients from ectasia, because the main problem were the 56 ectasia patients, because they were very few, they were coming mainly from one center. So the biggest amount was coming from one data center. The problem is that if we were using that data center as independent, we would have lost all the others. So the only way to solve this problem was to randomly select 80% and 20%.
Okay. Thank you.
Okay, thank you so much, Riccardo.